Well, good day, everybody. This is Chris back again with the Ancient Scholar, and in this particular video, what we're going to do is we're going to talk about some of the common issues that we run into with mechanical ventilation. I'm going to focus more on ventilator interaction and patient physiology. You all, of course, should be familiar with your immediate action drills if your patient's condition suddenly changes. The whole DOPE. I think DOPE is a good starting point. So those are your immediate action drills, if you will, your most pressing differentials, displacement of the airway equipment. So that is to say that the artificial airway has been displaced, pushed in too far, or pulled out of position, or something has been displaced when it comes to the ventilator circuit, right? That's D. The O is obstruction. Is there some sort of obstruction? One of the common things you're going to run into is kinking of the circuit and or tubing, right? Sometimes what you can get is you can get your inline suction gets dislodged or left in the endotracheal tube, and that can cause some obstruction as well. P is pneumothorax, and then E is some sort of critical equipment failure. All right, so those are that's your initial list of things that you want to consider and think about and run through when you have sudden changes in patient condition. Don't forget that you should always have a bag valve mask with not only the 15 millimeter adapter, but with a mask that you can seal over the patient's face in the event that you have a critical failure and you need to attach the BVM to an artificial airway, or perhaps pull the artificial airway and provide rescue ventilations through the BVM. The BVM should always be readily available to use as your backup ventilatory device. Okay, so with that caveat out of the way, I want to talk about some of the common issues that we run into. And the three categories of common issues are going to be patient comfort or synchrony with the ventilator. That's one category. The second category of issues are difficulty oxygenating, right? So we're attempting to better oxygenate the patient. And then the third category is ventilatory issues, right? We're attempting to blow off CO2. We're attempting to ventilate the patient better. I'm going to talk a little bit more about the synchrony aspect in subsequent videos. And so in this video, I'm going to focus primarily on oxygenation and ventilation. So when it comes to oxygenation, improving the patient's oxygen levels, getting more oxygen into the pulmonary system across the alveolar capillary membrane and loaded onto hemoglobin, right? So what are the primary variables that allow us to do that with the ventilator? So one of the most obvious variables is the FiO2, right? If I increase the FiO2, right, I increase the concentration of oxygen, the number of oxygen molecules in the gas that is being delivered. And so I'm going to increase the gradient, the concentration gradient that will tend to drive more oxygen across the alveolar capillary membrane into the patient. There are a lot of pitfalls that associated with increasing the FiO2 in the long run. High FiO2s, generally FiO2s that are going to exceed about 50-60% over a prolonged period of time, say hours to days, can cause things like increased reactive oxygen species. Oxidative stress can increase inflammation and lung injury, the so-called oxygen toxicity. And you can also have blood vessel changes, vasoconstriction and dilation, that can abnormally occur in the presence of elevated levels of oxygen. So those are things you've got to be concerned about, but this is certainly a quick way of doing that. So increasing the FiO2 can do that. And then the other way is increasing mean airway pressure. That is the average pressure experienced throughout the inspiratory cycle, both inspiratory and during the inspiratory and expiratory phase, right? That pressure is pressure that is opening the alveoli, that is driving molecules, gas molecules across the alveoli, oxygen, mainly what we're talking about here. And so anything that will increase the mean airway pressure is also going to result in improving oxygenation. Obviously, there are some pitfalls there. When you increase airway pressures, you risk increasing, right? You risk possibly overextending the lungs and causing volutraumas and barotraumas in certain patients, right? And so you have to be careful there as well, right? There is really no free lunch when it comes to mechanical ventilation. But with that in mind, what are the primary ways to increase mean airway pressure? Well, the primary ways of increasing mean airway pressure are going to be to do anything that will increase overall pressures in the airways. So increasing the tidal volume in your volume control ventilation. Now, obviously, there is a pressure limit, or actually, this is pressure control, so volume is a limit. But if I can increase my pressure and not exceed or increase the volume, that will increase the pressure, and I can just set my pressure control, my P limit, to go higher, so I can increase the tidal volume, and that will increase the mean airway pressure. That is one way of doing it, increasing the volume in volume control ventilation, or increasing the pressure, the PIP, the peak inspiratory pressure setting, in pressure control ventilation. The other thing that will increase mean airway pressure is increasing PEEP. PEEP is one of the primary mechanisms we have to oxygenate patients better, because PEEP is pressure that is always there. It doesn't go away, right? So you can see I have 5 of PEEP here, and if you look at your pressure time waveform here, you can see even during exhalation, so this is inhalation, exhalation, this is change in pressure as a function of time. Let me get rid of that. You can see it's always above 0 because my PEEP is 5, and assuming I don't have any leaks in my system, the pressure is going to be constant. So if I increase the PEEP to, say, 10, let's give it a couple breaths here, and look what just happened. The pressure that is always there, even at the end of exhalation, increases by 5, and that is going to result in an increase in the overall mean airway pressure. All right, so increasing PEEP, increasing tidal volume, or if you are in a true pressure control ventilation, right, increasing your P limit or your pressure setting, your delta P, is also going to increase your mean airway pressure. Another thing that can do it, but this is something that has some potential complications associated with it, is increasing the respiratory rate. The respiratory rate can increase mean airway pressure, but again, that can come at the cost of increasing minute ventilation, which can blow off CO2 and make your patient alkalotic, right? And so there are also some complications associated with increasing the respiratory rate, but at the end of the day, increasing respiratory rate can increase mean airway pressure. The most effective ways of increasing mean airway pressure are either to increase the pressure or volume and or increasing the PEEP. How do you know what your mean airway pressure is and if you're actually increasing it using the Hamilton T1 ventilator? Well, what you can do is if you select the monitoring option here, you've got these general, right, these 3 general things here, right? And if you look underneath the peak, that's the P peak, that's the peak airway pressure. Underneath that is the P mean. This 8.1 is the mean airway pressure. So what I'm going to do is, you notice it's 8.1, right? And so what I'm going to do is I'm going to get out of this and I'm going to increase my PEEP to 10 here. All right. I'm going to give it a couple breaths. And you can see on the pressure time scaler, right, my baseline is now at about 10. And then I'm going to go back into monitoring, and I've gone from 8 to 13 on the mean airway pressure. So that, in fact, has increased the mean airway pressure. All right. So that is certainly one way of doing it, by increasing the PEEP. And that is perhaps one of the most effective ways of increasing mean airway pressure without compromising, either increasing or decreasing the minute ventilation, having to mess around with the respiratory rate. All right, so PEEP is actually a very important component to that. Now, when you increase mean airway pressure, that means you have more positive pressure in the thoracic cavity, and that can come with its own problems. One of the primary problems is a reduction in cardiac preload and cardiac output. So you do need to monitor cardiac output very closely. And you're also going to want to monitor your lung compliance. And I'll talk a little bit about lung compliance and airway resistance monitoring and how that is really helpful when it comes to talking about obstructive pathologies and restrictive pathologies. But in this video, I just wanted to focus primarily on the major things that you can do to increase oxygenation if you're struggling to oxygenate your patient. Now, there are some other things that can be done that fall under the umbrella of what's known as inverse ratio ventilation. And that is essentially where you spend an incredibly large amount of time in the inspiratory phase, right? And you can do this with special modes like APRV, or airway pressure release ventilation. There are some specialized modes where you can do this. And you can also do this in your more conventional modes of ventilation, right? This does allow you to do APRV, and I'll talk about APRV specifically in subsequent videos, but just in your CMV or your PCV plus, you do have the ability to do what's called inverse ratio. So normally you're going to spend more time in the expiratory phase than the inspiratory phase. With normal pulmonary physiology, you're looking at about an IDE ratio of 1:2 to maybe 1:4. That's one part of your time spent inhaling and 2 parts of your time exhaling. So 1:2 to 1:4 is more or less normal. But if you spend more time inhaling than exhaling, right? So you can see that this ratio is going down, right? And now I'm at 1.4. Whoops. There's 1:1. All right. So what I've done is I now have equal parts inhaling to exhaling, and 1.1, I'm now spending more time in the inspiratory phase than the expiratory phase, and that is going to markedly increase my mean airway pressure. The problem with this is that gives me far less time to exhale. My expiratory time is low, okay? And it even gives me alarm, IRV, saying I'm now in inverse ratio ventilation. The problem with inverse ratio ventilation is that may impair the patient's ability to exhale. All right, particularly if there's any obstructive pathology going on. And so I can oxygenate my patient, and that's going to come perhaps at the risk of not being able to ventilate or manage carbon dioxide as effectively. So inverse ratio ventilation does come with its risks, but it is certainly a mechanism we can use to increase the mean airway pressure. All right. So that is addressing oxygenation. Those are some of the basic things we can use to address oxygenation by manipulating the FiO2 or manipulating mean airway pressure by increasing volume and or pressure. increasing the respiratory rate, perhaps, or increasing the inspiratory time, as well as primarily using PEEP as the main mechanism for increasing mean airway pressure. So hopefully you all enjoyed this video and found it helpful, and we'll see you in the next one.